Dr. Ann Hopkins for talking to us today about being a traveling surgeon. Tell us a little bit about your practice now first.
Well, it's a real pleasure to be here, Chris. I mean, I really just admire so much what you've done. Well, as you said, I'm a general surgeon. I work at NYU. I'm an associate professor of surgery there, and I've been there for almost 20 years, and just really love teaching and international healthcare. I think those are my real two passions.
Okay, so tell me about surgical volunteerism. How did you get into that? Is something that you always aspired to, or what? Tell us about the background of that.
It's like a long story, but yeah, essentially I've been working on and off with Doctors Without Borders, Médecins Sans Frontières, since about 1996, and I've been on their board of directors for 5 years. I've been off in the field. I've been to Burundi, to Sri Lanka, to the Democratic Republic of Congo. I feel like I'm forgetting something. Oh, and Chad as well, and with Haiti. After the earthquake, so I've been a lot of places, and I really got involved, I guess, sort of in college. I worked with my younger sister in orphanages in India and Somalia, and I think that kind of really whetted sort of my desire to go back into developing countries. Actually, I was a classics major originally.
Oh, wow.
Yeah.
Okay.
And so I had to go back and do all my pre-med requirements after I decided that that was going nowhere and that I should do something more sort of relevant to humanity, so to speak. So I went to medical school.
Okay. So Doctors Without Borders isn't usually entry-level surgical volunteerism. Did you do something first, or?
Other than working in an orphanage, not really. I guess I had gone to India for a month when I was a medical student. I was sort of an observer in a burn unit. I guess you would call it a clinical rotation. But I had done a fair amount of traveling, and I started working with Doctors Without Borders. As I said, this was in 1996, so I was actually a resident on my first mission. That's no longer possible. But I think it was a sort of a nascent organization in the United States. So that's when I first got involved with them, 96.
Okay. And so when you go to these things, just give us a rough idea of what sort of resources you have as a surgeon compared to your day-to-day job now.
Well, it's, you definitely rely on your brain a lot more. I think the resources, it's interesting sort of over the almost 20 years that I've been working with Doctors Without Borders, you can really see that our work has become a lot more sort of organized, if you will, and the equipment that we have has become a lot more advanced. But when I first started working, it was definitely rudimentary. We did have an autoclave in my first project, which was in Sri Lanka, and it was a functioning hospital. But the war that was going on there between the Tamils and the Sinhalese really prevented us from getting a lot of supplies from the capital. So at one point we actually ran out of antibiotics and oxygen, so that made things kind of difficult. In general, I think the thing that becomes most challenging is how far you're pushed in doing procedures that you've never done before, that you're not comfortable doing. Most of us in our training have done skin grafts, but usually with an electric dermatome. So using either literally just a scalpel or a dermatome, which is sort of a knife where you're
sawing.
Like that. Yeah, you're sawing. Can be a real challenge. Doing external fixations for me probably is one of the more difficult things that I've done. Cesarean sections was the first time I did one, probably the most difficult emotionally thing I'd ever done. And then I realized, wow, those are really, really easy to do. So you really end up getting pushed a lot, I think, to your limits of sort of what you remember, what you can do, that type of thing.
So what were some of the more, you talk about that emotional case, so what are some of the more striking cases you recall or interesting or scary situations that you were in as a volunteer?
I think the scariest situations are the ones where you feel that you could have saved somebody but you can't, and that's because of the lack of ICU resources. There are no ventilators in ICUs, and there's really no critical care management, and I think for me that's the emotionally hardest part to deal with. For instance, we had a 2-year-old baby that came in when I was in the Congo most recently who had been shot in the abdomen and had eviscerated omentum. and she had multiple injuries. I'm not 100% sure she would have been salvageable here, but we were able to get her through the surgery. I did several bowel resections on her, and fortunately most of her other vital organs had been missed. It was really bowel injuries and a bladder injury, colon injury, but there was no way to take care of her after the surgery, keep her warm, keep the fluids up, monitor her, and she ended up dying. So that type of thing, I think, is really, really difficult.
Sure.
On the other hand, you end up, doing things that are so outside of your realm. The first baby I ever delivered, I just remember thinking, oh my God, the APGAR scores are like 1 and 1.5. And of course they were 9 and 9. And the baby was beautiful and happy and healthy. And that is just like that feeling that you've done something, which you've never done before and have succeeded, is just so an exhilarating a feeling.
Yeah. So you usually go with the same organization? Has it always been Doctors Without Borders?
Yes. When I went to Haiti, I actually went with NYU. We sent a contingent down, but pretty much all of my international work as a physician has been with Doctors Without Borders.
Well, that's interesting. The NYU had a contingent. How were they supplied?
We brought our own supplies with us. Haiti was a very interesting and I think probably somewhat controversial situation because, number one, of its proximity to the United States, and number two, because so many of us in the United States have friends or family from Haiti. So almost every university was down there, and it was fascinating. I ran into one of my former residents who was down there. She showed up at the hospital, and I said, "Jackie?" She said, "Marianne." So it was really kind of funny. You run into all of these people. So I think that type of emergency does, brings out the best in our universities. It's harder for us to do if it's something, say, like the typhoon in the Philippines. That's much more logistically difficult for us to manage.
Right. And we feel like this is our neighborhood. A lot of people volunteer that probably don't volunteer in other places, perhaps.
Exactly. And in some ways, I hope that might have been the impetus for a lot of physicians to get more involved in global health.
So what would you say to young people interested in a career in global health?
Oh, do it. Absolutely do it. I think there's almost no feeling like the kind of feeling, as you know, of being out there in a situation where you're the only surgeon, like literally the only surgeon. Although I have been in a project where there are other surgeons as well. That's, oh boy, that's like a luxury to have somebody talk about it. But where you're there and you're with a tight-knit, small group of people, and you're operating day in, day out with the same group of people, all with the same goal, there is nothing more exhilarating, I think, personally, more exhilarating than really working in that kind of environment, with being people, with really having a purpose that, I know it sounds silly, but it feels almost broader than what we do here. There is no way that I don't think the same thing about my individual patients here, and that feeling I have when I'm taking care of them here. But the paperwork, oh my God, the rules, the regulations, and it's not that there isn't paperwork there. Believe me, there is. But sometimes I think nowadays with all the regulations, you feel like, you're most of what you're learning now, your CME, if you will, is on regulations and rules and this type of thing. And there, it just feels like a very pure form of medicine. I think you don't have a CAT scanner. I sometimes joke I'm the CAT scan machine, i.e. if somebody really is concerning with their abdomen, you do a laparotomy, and that's the CAT scan. So
the retinal scan, I've heard it said.
Oh yeah, that's fun. That's true. I remember I once had to do a barium enema on a toddler who had an intussusception. Classic story. You could feel the mass there. I'd never done a barium enema in my life. I had no idea how to do it. I was on the x-ray table with essentially a funnel. It was sort of like a cup with a funnel on it hooked to a tube. I put the catheter in the rectum of the child, and the mother passed out cold on the floor. I was like, and thank God I was able to reduce it with the barium enema. But oh my God, you're like, I think I must have been covered in barium by the end. I was probably glowing in the dark. So, but, you have to have a sense of humor sometimes when you do this.
Indeed. So that was a situation where you had a You had X-ray? You had X-ray available there?
Yeah, in
Okay.
Sri Lanka, I had an X-ray and a sonogram. Unfortunately, at that time, I trained in the '90s, so we didn't do fasts all the time, and I had never been trained in sonogram, so I was not 100. I never. Where's the instruction manual?
Right.
The only thing I really diagnosed there was a polycystic polycystic liver, and I think, but a pregnancy. That I correctly diagnosed. Woman who had a tumor, not married, no sexual relations with I think it was the ICRC security guard's fiance. No, they'd never had sex. And then, sure enough, there was the beating little heart. So that was I don't know what you would call that, a little bit of a surprise.
Surprise.
Yeah.
So share another favorite case story with us, or another fun one.
Gosh, it's hard. And in fact, I always tell my residents, I mean, the case, every case is fun. So we're all surgeons, we know that. But sometimes I think I want to make sure that residents and students and doctors that plan on doing volunteer work know that most of it is thoroughly non-glamorous. It is a lot of abscess, a lot of debridement, a lot of burns, sort of really the bread and butter stuff, because a lot of the more complicated things like the gunshot, although you'll see plenty of gunshot wounds with Doctors Without Borders, sort of the glitzier cases, they don't survive. They're curfews usually, there's not really an ambulance system, and so you don't often see those sort of complex and cool cases.
Golden hour cases.
Yeah, exactly. That being said, you will certainly do trauma laparotomies. You'll do laparotomies with perforated typhoid. I'd never seen it. It was crazy. An appendicitis that was a worm. I don't know if you call that a cool case or gross. Or this long little worm came out of the appendix. It was so disgusting. An ectopic pregnancy. God bless gynecologists out there. I have absolutely no idea how they do that. This little globule with a fetus in it. That was crazy. But I think for me, the ones that have meant the most or have been like the most exciting. I mean, it's going to sound weird. The kids with orthopedic injuries that I can calm and comfort, and because you have to take them back to the operating room so frequently, that physical contact, the whole, a lot of them, it's not really in their culture, and I always sort of am at the head of the table with my hand on, their shoulder or something like that. For me, those are actually the most gratifying. Yeah, you're debriding a wound. I had to do a hemipelvectomy on a young, I think she was about 6 or 7 years old. That's not a fun case, by the way. But, getting them through and having that everyday interaction, I love. Wow. I think obviously the coolest cases are the trauma cases where you have to work by yourself with a nurse really fast with multiple injuries. I've only ever seen high velocity gunshot wounds probably actually in Sri Lanka in the military, because they're the only ones that can get to the hospital fast enough with a high velocity. And it's amazing when we read about it in textbooks with a small entrance and the huge exit. And this patient had clearly an acute abdomen. I couldn't even find a bullet hole on the anterior abdominal wall. But posteriorly, there was a teeny weeny little hole. And I lapped him, and it was literally as if someone had taken a machete and chopped up his intestines. Wow. It was there were, I can't even, I don't know, 8, 10 through and through enterotomies. Crazy.
Wow. And how did you manage that?
Oh,
post-operatively.
Post-operatively, he didn't really survive because he also had a pancreas. He had a stomach injury. He had pneumothorax and a traumatic amputation. Oh, wow. Triaging that is very, very difficult. The amazing thing with him is that blood banks, as you can well imagine, are not stopped. They're not like here. You have to bring a family member to donate blood, which brings up a lot of ethical questions on potential HIV or hepatitis transmission and screening processes. But with this man who had been a soldier, every soldier with that blood type lined up. And outside of the operating room, I had as much blood as I wanted. So we actually operated, I think, for about 5 hours as I completed the amputation, got hemostasis, did the laparotomy, did the bowel resections, or damage control, et cetera, and then with the pancreas, And I was going, and remember, my first mission was Sri Lanka, and I was a resident, so of course I'm freaking out. And I broke scrub once or twice because the surgeon, I'm not even sure he was a surgeon, but the military officer with the military was there, and I was explaining what the injuries were and that he's still alive, but the chance of surviving this is pretty much zero with a traumatic chest, abdomen, and leg injury. And then it was funny because as soon as I said, and he has a pancreas injury, it was as if I had said he had a fatal gunshot wound to his heart. They were like, ooh, pancreas. Yes, it's bad. So we just continued operating. He may have gotten to the recovery room, but again, there is really no postoperative ICU care,
right.
Which is it's really a challenge and heartbreaking at times.
Yeah. Well, last words to the general audience about surgical volunteer work?
Yeah, it's something I can't even imagine living my life without. It has been the most transformative experience, period, of my entire life. It's changed my outlook. I think it's made me so much more easygoing, a much more competent surgeon in a lot of ways without getting ancillary tests. But most of all, I think that, the pride that you have in having really done what you went to medical school to do is really just amazing. And living in another culture, even if you're not fully integrated, because you really can't be fully integrated, you will never have an experience like, an immersive experience like that where you have nothing. And the staff, the nurses that I've worked with, and the other physicians and anesthesiologists who were either Congolese or whatever, are just amazing. And the amount of, it'll sound ironic, but you're there in the middle of a conflict zone, but the amount of laughter and the shared joy and the camaraderie,
real sense of purpose.
A real sense of purpose.
Yeah.
I have never found it here. And I find it, it's not that I don't have it, it's just I would say it's amped up 100-fold.
Right. Very good. Well, thanks for talking today. I'm inspired. I'm ready to go again.
Me too.
We'll talk again soon.
Thanks so much, Chris. Bye-bye.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook. Follow us on Twitter. And find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.